That should be Formula Ford circuit. It's much slower, much safer, much easier. Thank you. I'm honored to be here. And I'm going to talk to you about why I like being a doctor and why it's fun and why hopefully some of you in the IBA program will think of becoming one because it's useful. This is me when I had hair in 1984. My kids looked at this and went, "Who the hell is that?" What had happened was I was in the middle of medical school. I'm Irish, I lived in Dublin, and I went to the Royal College of Surgeons. I had raised money to go to a Tibetan monastery in India by selling flowers on Valentine's Day in the streets in Dublin. So I took off there and went there in June for 7 weeks, and I found myself with about 2,500 monks, and I was the only person with any medical training. This was quite an experience for me. And it's changed how I practice medicine. I had with me 2 books. This was one, tiny little book, great book. Somebody took time to write a small book. It's really easy to write big books. I've written 2-volume textbooks because I didn't have the time to write a 1-volume textbook. And the book on the right, Where There Is No Doctor, is phenomenal. It's been translated about 75 million times, printed 75 million times in 50 different languages. And it's saved more lives than any other book I'm sure I'll ever come across. So at night time in this monastery on my own, I read these things back to front every night, and I consumed them with an intensity and a focus because it was the only source of information I had. And it really makes you focus when you're like that. And these books require no batteries. We always hear about how great the web is and everything else, but a lot of the world is lit by fire, not by light bulbs at night time. And we need to think about what is sustainable, what is useful. iPads and iPhones remind me of jewelry often, and they're sort of fads, but books work, and you can read them with a candle. So I think that's important to remember. So when I got there, there were 2 places like this to wash and to get water for cooking and drinking and to wash your clothes, and they were almost like the primordial soup from which we came. There was a swamp around with strange creepy crawly things in them. And because of this, the kids were getting scalp and wound infections. They were getting all sorts of horrible ulcers in their skulls. Remember, monks shaved their heads, and what they were doing was they were shaving their heads with the same blade. They would do 30 or so until the blade was dull. And so they were transmitting these infections from one to another. They also had a major problem with diarrhea and worm infections. So we built, with the permission of the abbot and his colleagues, after some diplomacy, great washing areas. And the monks knew exactly what they had to do. I just had to provide the money and the sort of strategic diplomacy to get it done. So we built these wonderful washing areas. You can see all the monks standing around proudly after their work is complete. And we built 2 of these. It was very simple, very effective. We then had 4 or 5 days of hair washing to get rid of the fungal infections every day, a couple of thousand monks getting their heads washed to stamp this thing out. With the remaining money, I did 2 things. We bought an unbelievable amount of anti-worm and anti-protozoal amoebic dysentery, giardiasis type medications in the local town. And then over a weekend, we treated the entire monastery. So by Monday morning, the younger monks were competing to see who was passing the longest worm. It's quite disgusting. But not something to be proud of, you know, this long. But so it was very effective. About this stage, I had about a week left. I had to find some way of making this sustainable. So I love mangoes, and we went to the local city and we bought about 300 mango trees. And we planted those around the monastery, and each mango tree produced about 1,000 mangoes, 1 rupee each, 1,000 rupees, 300,000 rupees for a sustainable source of medication and fruit in the diet. And I wonder how these guys are now. It's quite a while since I saw some of them. Many of these children won't become monks. It's more like education for them. It's more like university. They go back to their villages. But this profoundly affected how I perceive medicine. And I became an academic physician, so other doctors send me patients to treat. When somebody is unfixable, or in their perception, their hospital, they send their patients to university centers for care, like Toronto General, like Toronto Western, Johns Hopkins, places like that. And it's a great place to practice medicine because you deal with difficult things. there are three stools, three legs really to the stool of being an academic physician. You treat patients, you train people to be doctors, whether they be undergraduates or pre-med students or medical students or residents or fellows or your colleagues, and you do research. And my research has been focused primarily on making what I do so simple that other people can do it. Like Mary Robinson, an Irish president, said, you want to do your job, not keep your job. So to make something so simple, it can diffuse across economic barriers between your hospital and another hospital. We're awash in technology, and we lose the signal-to-noise ratio in things. There's so much noise. When we create a talk or teach somebody, often we have megs and gigs of information, and we can't share that. We have to simplify it, like we saw earlier, to cell phones. We have our Blackberries and our iPhones going off and distracting us. When we design technology, particularly in hospitals, we design with this kind of mindset in mind. The Airbus A380 magnificent device, really rather irrelevant. And when it comes to healthcare, we're very bad at designing things that are cheap. The last thing you want to do is invent something cheap. Nobody's going to make any money. So, I'm going to give you 4 examples of technologies I've been involved in inventing or developing that are really deliberately cheap. Around the world, if you don't die of disease or in some horrible war, you're going to probably die of a motor vehicle accident, probably through multiple fractures. In Kenya, in those tuk-tuks, you'll see 30 or 40 people in a tiny Toyota minivan. So when we treat fractures in this world, from an accident on the 401 or I-90, you open the spine, you open the skin, and you put in hardware, much like hardware you find at Builder's Square or Canadian Tire, but very expensive hardware made of titanium, made by companies like Medtronic. This would be a $40,000 procedure, basically, and it takes the lumbar spine, our lower spine and sacrum, and instruments it and makes it stable like the Sydney Harbour Bridge. So a group of us, okay, how do I make that? There. A group of us came up with this technique in the late 90s. This is one of my needles. It's a needle in a vertebra. This is the 5th lumbar vertebral body. The needle costs about $60. And through that we inject plexiglass. Plexiglass is a material that was designed to build windows for World War II bombers. And it sets up very quickly, and it becomes a glue. And you can glue fractures together by doing it that way under X-ray guidance. This is about a $400 procedure. So this is done 50 or 60,000 times a year worldwide now, in tumor, in trauma, in osteoporosis, and it's very cheap and very effective, and we're proud of that. In many parts of the world, somebody's only asset is their physical strength. It's how much you can carry, how much can you put on your head, what load can you carry on your back. And they get disc herniations. And you see on the left side a normal MRI of the spine. It's a brilliant design. You couldn't design something as beautiful as the spine, really. And then on the right-hand side is a spine with a disc herniation. The arrow is beside that bulging disc, and people get pain radiating down their legs. It happens in the neck. You get pain down your arms. And this is debilitating. You can't work. When you can't work, you don't get paid. You don't eat. So treating these in a simple way is important. Here again, you have surgery. You open the spine. You move apart the tissue. You take out the disc. And if everything goes well, you will be great. About 15% of the time, it doesn't work so well, and people have chronic pain. I have a crazy Italian friend, and as many of us clearly do. But, you know, we came up with the idea of using ozone to treat herniated discs. On the left is my device for that. It's an ozone generator that's disposable. It's about the size of a syringe. You can hold it in one hand. It's not much bigger than this. And basically, we create lightning, or an electrical discharge, from the batteries in the device into the syringe, which is filled with oxygen, converting O2 into O3. And then the needle that you see in the middle there is passed into the disc, and the ozone is injected into the disc through that needle. So under X-ray guidance, the white line on the left is a needle, is the needle into the disc, and then on the right-hand side you see the image of the gas after it's injected. The O3, very unstable material O3, breaks down the protein in the disc into carbon dioxide and water. and that is a lower volume than the pre-existing protein. So the pressure on the nerve is less, and the pain goes away. Ozone is also a sterilizing agent. It's used to sterilize equipment in hospitals, so you get less infections. So again, a minimally invasive way of treating something. One of the beauties of working in an academic environment where you receive ill patients, a tertiary referral center, kind of a third-level hospital, is you're under pressure. We are carbon-based life forms, right? So when you put carbon under pressure, you make diamonds. I think this is one of the key things to remember. Many of us shirk pressure, but we shouldn't, because that's when we're at our best. It's Remembrance Day today, and we respect the men and women who have given their lives around the world on all sides for what they believed in and the safety they give us. In the movie we saw earlier, you saw the presence of a red cross. It shows the role of medicine in warfare. Most great advances in medicine have occurred through warfare. If you think of Florence Nightingale in the Crimean War, you think of the ambulance being produced in the First World War, driven by Ernest Hemingway in the Spanish Civil War. You think of burns and skin grafting developing to treat Spitfire pilots who were burnt in their airplanes in the Second World War. The material in this submarine is the basis for the nitinol stent used in coronary arteries. There are many things that have come from warfare that in fact save our lives, blood transfusions. On the surface of that submarine you can see tiles. Those tiles feel vibration that are sounds. They travel blindly under the sea at 30, 40 miles an hour, listening quietly. I've had the pleasure of working with a bunch of guys, Pete Neal and others from the ship Nautilus over the last few years. We've taken these tiles to measure the vibration of cerebral blood flow. So when your heart beats, it pushes a wave, a volume of blood up your aortic arch to your carotids into your brain, and your brain expands. And it pushes the cerebrospinal fluid against the inside of your skull. A pounding headache. What are you feeling? You're feeling that pounding. It's amazing. That brain is a pump. It drives CSF flow. So we can feel that vibration with these accelerometers that we've taken from that submarine to detect stroke. If you have a stroke, you have asymmetric blood supply. Only one side is moving. It's easy to pick up. Where else is this relevant? If an improvised explosive device goes off and some young men are injured or wounded, you want to triage those who are salvageable versus those who are not. Is this person concussed? Do they have devastating brain trauma? And young medics make a decision in the field to decide who gets evacuated and who don't, who's salvageable, who's not. It's binary. So we can use this in warfare, or we can use this for stroke detection. So we look at this wave of energy that comes from our heart and then drives the brain to expand. And we can create a waveform of that happening. This would be normal. So we're measuring the vibration of the brain moving. Okay, so the last leg of the stool that I'm interested in, as it were, as a teacher, is being a teacher. I'm very conscious that we hoard knowledge. We don't share our knowledge. In Kenya this summer, I was very impressed, as were you, by the use of cell phones. Many of these Kenyans will have 2 SIM cards in their cell phones. They're far more advanced than we are in what we do with them. They charge their cell phones the way we used to run our lights on our bicycles, by having battery-mounted generators to charge the cell phones. Brilliant. So when we teach, we have to teach to that level of technology. We have to be aware that we do not all live in the same century, and that we teach primarily to a world lit by electricity. This is a map of the world at nighttime. But the areas that are dark, the parts of the world lit by fire, are the places that we have to send information as effectively as possible. And this hoarding of knowledge, you know, is a strange thing. Normally, many of us who are teachers will teach into a room like this, and when we leave the room, the teaching is lost. So we have to capture it in a way that it can be shared. And when we share it, we have to teach it in a way that can be delivered to cell phones. We have to take the time to write something simply, which is much more difficult to take than the time taken to write something in megs or gigs. So at UHN, Toronto General Hospital, and University of Toronto, we're working on something called Osler.edu. Osler was one of your famous Canadian physicians He was probably the greatest physician who's ever lived. He specialized in bedside teaching and one-on-one dissemination of information. He developed a loyal cadre of teachers at McGill, at UPenn, at Hopkins and elsewhere, and he was a wonderful teacher. We're going to put up on this thing really boring stuff like standard operating procedures. When you have chest pain, how do you handle that patient? When you have pneumonia, how do you handle that patient? When you have a UTI, all these things we've worked out that we take for granted. Because checklists of standard operating procedures save lives, just like pilots use them in airplanes. When you simplify something so elementally, you reduce the ability of humans to make mistakes. So we're working on this actively at the moment. There'll be one element of it that's very important to me, and that's where we give all the people who are the recipients of the information an opportunity to contribute information as well, to make people audible. Because very few people actually get to be heard. Very few people ever have the opportunity, like I do now, to actually say something to a room full of other people. And yet all the people involved in this network will have something worth saying. So on 12 noon on Fridays, as the time zones roll around the world, each site that we engage with will have the opportunity to upload new lectures and to be heard around the world. So I just go back to that experience in the monastery. This taught me very much how little I need, but my responsibility to teach, my responsibility to try and persuade other people to enter into the world of medicine. And some of you perhaps will decide in your IBA programs to go to medical school, and I hope you do. I don't think you'll regret it. Thank you very much.